to having fruitful discussions. And welcome to those that are joining us also through the various platforms that are on offer. The participants joining us from the Africa CDC channels, that is on YouTube and also on Facebook, welcome. And my name is Lizzie Sitole. I'm from ICANN, and I'm your host today. So to start with, today our session is on hand hygiene. And before we start the proceedings of the day, I'm just going to run through a few housekeeping rules. First and foremost, we are going to post a poll whereby those that are joining us through the Zoom platform, you can be able to fill it in just for us to get to know you, who you are and where you're coming from and which type of facility you are working in. And then after that, we have the Q&A box and the chat box. May we kindly make use of the question and answer box just for the questions only. I repeat, may we please reserve the questions for our Q&A chat box. And then for the other chats, we can make use of the chat box. Thank you. And please note that we are going to provide a certificate of attendance after the end of this series. The series has 6 sessions, and for you to be able to acquire a certificate, you have to attend at least 4 sessions out of the total of 6. So today we are in our second session, and we still have 4 more to go. And also you have to ensure that you attend for more than 60 minutes during the 90-minute session. So Susan is going to post the poll so that we can fill in for now. And then we'll also encourage you to join the community of practice, and the link will be provided in the chat box. And if you need to access any COVID-19 guidance or IPC guidance, please feel free to log into the Africa CDC website and also on the Infection Control Africa Network ICANN website. And as I said today, we've got the Portuguese and Arabic interpretations that are ongoing with this session. Without wasting much of your time, I'm going to introduce Dr. Idou Latef, who is the ECHO platform coordinator under Africa CDC, who will give us the epidemiology updates. Over to you, Dr. Idou.
Thank you very much, Lizzie. Can you all hear me?
Yes, we can hear you.
Thank you very much. Good morning, good afternoon, and good evening wherever you are joining us. As Lizzie has mentioned, I'm Idou Latif. I'm trying to put up my screen now. Yes, can you see my slides?
Yes. Yes, Idou.
Yeah, thank you very much. Yes, I'm going to walk you through the epidemiological situation of COVID-19 pandemic as of today, 27 January 2021. Looking at the COVID-19 situation globally as of 4:50 p.m. Central European Summer Time, 26 January 2021. The map shows the countries reporting COVID-19 globally, and the darker color, the darker blue, shows countries reporting more than 1 million confirmed cases. And there are about 18 countries, of which one of them is South Africa. And the panel on the right shows the epidemiological curve of COVID-19 cases reported daily by World Health Organization region from 9th of January 2020 till yesterday, 26th January 2021. The y-axis shows the number of new cases reported by day. And as you can see, the yellow color represents the PAO region, and the darker red represents the African region. Overall, more than 99.3 million confirmed cases has been reported, with more than 2.1 million deaths, resulting in 2.2% case fatality rate. Moving to Africa, this slide shows the COVID-19 situation as of today, 27 January 2021, 9 a.m. East African time. The y-axis shows the number of new COVID-19 cases by day. The red line shows the 7-day moving average. And as you can see, we have a downward trend, which it has been for the past 3 weeks. And this is as a result of the decrease in the number of cases from Southern African region. The gray color represents the Southern African region, and the green color represents the Central African region. Overall, we have more than 3.4 million cases reported in Africa, with more than 86,000 deaths, resulting in a case fatality rate of 2.5%. And out of all these confirmed cases, 85% have recovered. This slide shows the cumulative COVID-19 cases by African Union member states. And this is categorized into 5. The first one is one country with no reports. 23 countries are reporting between 1 and 10,000 cases. 22 reporting between 10,000 and 100,000 cases. 8 countries are reporting between 100,000 and 500,000 cases. And only 1 country is reporting more than 500,000 cases, which is South Africa. This table shows the COVID-19 situation by African Union region, the distribution of the new cases. In the last 24 hours, we have a total of more than 15,000 new cases, 918 new deaths, and over 20,000 new recoveries. And as you can see, the majority of the new cases, the new deaths, and the new recoveries are from Southern Africa region, which is more than 10,000 new cases, 798 new deaths, and over 16,000 new recoveries. This slide shows the case fatality rates by African Union member states. And in the EPI week 3, that's from 18 to 24th January, we have 1 country with no information, 12 member states reporting less than 1% case fatality rate, 21 member states reporting between 1 and 2.2%, 18 reporting more than 2.2 but less than 5%, and 3 countries reporting more than 5% case fatality rate. And these 3 countries are Sudan, Egypt, and Sahrawi Republic. This slide shows the total COVID-19 tests conducted in West African region. In the whole of Africa, more than 30 million tests have been conducted. But going down to West African region, we have more than 4.3 million tests conducted with 13.9 tests per case ratio and 7.2% positivity rate. Thank you very much. Over to you, Lizzie.
Thank you so much, Dr. Ido, for that update. As we can all see that there is a lot that we need to do as infection control practitioners. So without wasting much of your time, I'm going to introduce our next speaker. Her name is Georgia. She's an assistant professor at the London School of Hygiene and Tropical Medicine. And her main focus is actually on infection prevention and control in low and middle income countries. She started her work in 2013 within the Make for Mothers project, and he joined the Soapbox collaborative research team. Prior to this, she has worked in South Sudan. She has worked in Indonesia. And she is very, very passionate about infection prevention and control. So today she's here to share with us the behavior change strategies to promote hand hygiene after we have collected observation data or compliance scores. Professor Georgia, over to you. Thank you.
Thank you very much, Lizzie. Can you hear me? Okay. Can you hear me?
Yes.
Yes, we can hear you.
Okay, fantastic. I'll just proceed to share my slides. Can you see them okay?
Yes.
Oh, brilliant. It's a real pleasure to be here. I've started to collaborate with Africa CDC back in May, just after the beginning of the pandemic. So I've learned a lot from Africa CDC, so I'm really glad I'm here today. So I'm an epidemiologist by background, and I work a lot also with the behavioral sciences, specifically on behaviors related to infection prevention and control. And today I'm gonna talk about observation. And what I really want to emphasize is that we use observation in our daily life. You all observe a series of actions, environments, and you already have that in yourself. You already know how to do that. So today I'm hoping that I'm talking you through something you already know and just giving you some tips on how to do it in your context to maximize and support behavior change in those contexts. And observing is a bit like a nosy neighbor. You kind of try and capture what's going on around you. The difference with a nosy neighbor is really that we shouldn't make a priori judgment when we try and observe. Of course, you have to make a judgment about what behaviors are correctly done and what are not. But I do encourage you when you observe to avoid making a priori judgment about why a certain person performs a certain behavior or not. And I can go into a little bit more detail of this later. So to start with, I would like to start by making you do a little exercise, which is essentially look at this picture, which is a labor ward. It's a very busy labor ward, about 600 deliveries per month. It's in Eastern Africa. And this is a place where I've carried out a substantial amount of observation. And I would like to ask you, looking at this environment, do you think the environment is well set up to perform hand hygiene, but also to prepare quickly for a delivery? And I'm going to give you some tips of where things are. So, of course, this is the sink and the soap. This is where the sterile equipment is. On the top of the trolley, you have the gel, and then you have gloves that the birth attendant brings from her own household in her own personal bag on the right-hand side. And there is no drying material for the hands. Now, can you put in the Q&A box, can you put some observations about this environment and what do you think is going well and what is not going so well in this environment? Do you think it will be easy or difficult to perform hand hygiene here? Please take a minute to observe the environment and make some observations. You can use the Q&A box. Anybody? Okay, so I think you guys completely hit the nail in the head. You're talking about how the flow doesn't make much sense, and you're completely right. I mean, the sink and the soap are on the other end of the spectrum in the room compared to where the gloves are. It looks unhygienic, the whole environment. The setup is not well done. Very poor housekeeping and cluttering. Yes, absolutely. There are no hand hygiene posters to remind of hand hygiene. Of course, there are other structural issues like the toilet being there. The space is limited. The gel has to be near the sink. Fantastic. Yeah, I mean, you basically hit the nail in the head. There are loads of elements of the environment in this picture that are not conducive to perform hand hygiene quickly and to do it in a way that even with heavy workload, you feel in control of the situation. And as you can see, you already have, you know exactly what to look out for. So your responses are great. So I want to give you another example in the next slide. This is actually a transcript from an observation we did again in a labor ward. There are two nurses that are going to attend a woman about to deliver. They perform adequate hand hygiene to be able to catch the baby. So we're very late stage labor. And I'm going to read you what's happening. So while the woman is getting down the bed because she would like to walk, the Macintosh falls down the floor. Nurse A picks the Macintosh up with her sterile gloves. While doing so, she's observed struggling not to touch the floor, but she touches it a little bit. Nurse A asks the woman to get back on the delivery bed. Then Nurse B also touches the woman's legs while assisting her to get back on the delivery bed. Unlike Nurse A, Nurse B does not seem to care about not touching the woman or her surrounding. She touches her clothes, the Macintosh without any precaution. She does not seem to try and keep her hands away from things as Nurse A. So from this observation, again, can you let me know what do you think went wrong, or what went well, and what do you think it tells us about hand hygiene, this observation? Again, you can use the Q&A chat box to do that. So we have an example of one nurse that is super careful about not touching things, and one nurse that is not so careful. Yes, exactly. So there is possibility of cross-contamination. Yes, exactly. So you guys, again, you're making very much the right points on the chat. Nurse A should have changed her gloves. Yes, exactly. That would be the absolutely correct practice after having touched the floor. Good. Fantastic. Yeah, so basically you made exactly the right relevant observations here. There is an attempt to keep hands off surfaces from one nurse, but not the other. So it's obvious that there is an understanding that you need to keep hands clean up to the point of the procedure, which in this case is catching the baby. But somehow one nurse has much more care for that than the other. And one thing that you can do in this case is, for example, understanding why one nurse is much more keen on that or the other. Maybe they had a role divisions, one was going to catch the baby, one wouldn't touch the baby, but it's unlikely because they're working together. So probably both of them would have had to keep their hands clean. But this is just to give you a flavor of the fact that just by looking for 10 minutes at the procedure, you can tell a lot about what went wrong in a sequence of behavior and what goes wrong in the environment to support that behavior. But also, I hope it gives you the confidence that all of you know what you're looking for when you're observing, and it can be as simple as jotting down the sequence of actions that people perform. So what should be the aim of observation? The aim of the observation should really support behavior change, and that can be done directly because by observing, we show people that we care, but also indirectly by collecting useful information to support behavior change. And that's what I'm going to focus on for this presentation. I would discourage you to use it to be coercive or to be punitive or to establish a blaming culture. This should not be a big brother situation where you're trying to tell off individuals. You're just trying to collect information to support people to perform actions better. So how do we observe? So one really, really key thing sorry? Okay. So one really important thing when you're observing is to be in the right frame of mind. And this is not trivial. If you know the context already, this can be positive and can be negative. It can be positive because you already, the amount of information you're processing, it's a bit less than if you're observing an environment or an action for the first time. But it can also be negative because you have a priori judgments about why things are working in a certain way. So my advice is that try and be a blank canvas the first time you observe something. Try to be a blank sheet where you're just thinking, okay, this is what's happening without no priori judgment. And then you can look at it later and think, okay, what was going on there? So one thing I do a lot, especially at the beginning in a new environment, I just jot down every single action that the health workers are doing. And then I look at it later and think, okay, what was going on there? And also look at the actions, but also look at the environment where these actions are taking place. Another thing I suggest is start usually with looking at one person because it's quite a lot already to jot down every single actions. And as you go along, you can look at multiple people, but only when you feel confident that you can capture really the full sets of actions they're undertaking. Of course, you can just do one observation or you can do multiple observations. This depends by your objectives. Obviously, if you do multiple observation, you accrue more information about the context. And unless you're doing a quantitative exercise where you already know that you want to do systematic observation to reach a certain numbers, I would suggest to do, at the beginning, 8-10 observation of a certain behavior and think, okay, did I reach saturation? A bit like with other qualitative methods where you are thinking, okay, did I get new information by the 10th observation, or do I always see the same patterns? If you always see the same patterns, it means you kind of reached sort of a good level of understanding what was going on. Another thing to think about how to observe is whether you want to be hidden and conceal the fact that you're observing and what you're observing, or whether you are participating and engaging with the people who you are observing. So usually I start with concealed observation. Obviously, you have to tell people you're there to observe them, but you can say, for example, that you're observing broader quality of care and not specifically hand hygiene or environmental hygiene or whatever you want to observe. Once you get a lot of information already, you can use participating observation to get more information from the participants. So for example, you've realized that the location of certain equipment is in the wrong place, and you can ask directly people, oh, how do you feel about the gel being there? Or why did you do that? So you can use additional questions to get more depth about your observation. One thing to advocate is to pick the right tool for observation. For example, there is a WHO observation tool for hand hygiene, and that's a very, very valid tool to do several observations simultaneously, specifically on compliance to hand hygiene. However, of course, like every other tool, there are limitations. It doesn't tell you much about gloves pattern or whether there are recontamination events of the hands and the gloves. So it really, you have to think about what do I want to observe? And as I said before, I think the best way to start is really just to do a few observations where you jot every single action of the health workers. And it also depends, of course, on your time and resources. Sometimes you have limited time, sometimes you can only afford to do observation yourself, you cannot hire anybody else, and therefore you have to be conscious of that. But make sure you have really clear objectives. Think about, what behavior you want to observe before diving in. And what are you going to observe? Of course, you're going to observe mostly actions, and I do encourage you to also look at the environment and how people move in that environment. And ideally, I would encourage you to start broad. Many times you don't really know what is going wrong. So try and observe the entire sequence of actions rather than focusing on just one. For example, when I was observing compliance to aseptic procedures, there are different actions that a birth attendant needs to take. And for example, you have to first hand wash with the right technique, right duration. Then you have to dry hands. Where do birth attendants dry their hands? Then you have to make sure your hands do not touch unclean surfaces. Then you have to wear gloves appropriately, what gloves are you using, how you're going to put them on. And then again, the gloves have to be kept clean up to the point in which you provide patient care. So we started very broad, and actually we realized we collected more than 900 observations. That a big deal, contrary to what we expected, was the problem of recontamination. Health workers were attempting to wash hands and put on clean gloves, but 50% of the time they were doing these clean actions, then they were touching unclean surfaces that could lead to cross-contamination of their hands, and therefore eliminating their clean action to begin with. So then, of course, the behavior change solution to recontamination is different to the one of getting people to the sink or the gel. So you can also observe relationships, power dynamics, but it's much harder, requires more time, but just be very clear in what you would like to observe. So the next step is follow up on what you observed. You collected your information, you think you know what's going on. And then I think it's always good to feed back directly to people that are involved and asking very open questions. Why did this happen? And you can do this in groups or individually. How did it make you feel? Was that a good alternative? How would you change it? It's also really important to feedback on your results and say, this is what I observe. And people respond very well, and that can itself lead to behavior change. And ask people to speak up and be honest, because only valuable information will help you to improve. And be humble when you give feedback, because it's not easy to do observation well. Sometimes you miss some actions. So be prepared to say, okay, I'm sorry, I didn't see that. This is a quote we got from a focus group discussion where we fed back the results. And it says, I think hand hygiene is currently not a priority. This is why they even don't insist on hand hygiene during morning meetings. So obviously this is a clear, direct information. The leadership during the morning meetings does not promote hand hygiene. And you can see that that's one of the drivers of poor compliance among health workers. I think there is some background noise. I'm sorry. May I ask people to mute their mic? Apologies. This is just to show you how valuable it can be to feedback the results, because people say, well, I think, managers don't care about it. Why would I care? So you can sort of talk about the drivers of that actions. So then what do? You fed back the results. People have suggested you potential solution, why they do things. So now you have to think, okay, I think there is an intervention here. And I need to make sure that I use all the information I collected during observation to adapt this intervention to my context in the best way. So this is just one example on the right-hand side of psychological drivers of behaviors in general. You know, they're made of different elements, knowledge, habits, environmental constraints, beliefs, norms, perceived control. Obviously, you need to think about all of them, but you can narrow down what you think is the crucial thing. And from the example I've given you before, we all agreed that environmental constraints were a big barrier. And once we've identified what you think are low-hanging fruit, apologies, I think there is still someone with their mic on. There's a bit of background noise. So once you identify the potential driver of your behavior, starts with low-hanging fruit. So what can I do to improve the environment to support the behavior? For example, this is just one example of how to go about it. And once you think about the solution, so what solution do I think about it? Also think about it in a behavioral way. Now I'm going to give you an example. So we realized that the workflow was not very conducive to hand hygiene. So we decided, okay, let's introduce hand gel. But introducing hand gel also has behavioral connotations. So first of all, we wanted to understand, how do people feel about hand gel? If we introduce it properly, you know, if we expect them to use them 99% of the time, how do people feel about it? So we checked their beliefs, and we realized that people didn't think it was as effective as water and soap. So we showed them very powerful videos showing that, you know, if you put your hands on an agar plate, the effectiveness of water and soap and gel are similar. We also knew that people felt they didn't have enough time to perform hand hygiene when they had heavy workloads. So we did a race to show them that actually hand gel is quicker than water and soap. So we thought about all the ways in which we could incentivize in a behavioral way the introduction of hand gel. And also then we thought about location. So we thought, okay, so if the infrastructure, you know, if the sink is so far from everything else, one good thing about gel is that you can bring it with you. So we all gave them both common bottles and personal bottles. That actually meant that the access to hand gel was very, very close to the point of care through the personal bottle. And in our context, the personal bottles were really much loved, and they were used in 90% of cases where hand hygiene was performed. I would also encourage you all to pilot first. Whatever solution you think you're going to implement, pilot it for a week or two and see if it works and see how you can improve it once you implement it. For example, another thing we piloted was the introduction of delivery kits. That would mean that all the delivery equipment was in one single location. And also we thought about, with the birth attendants, but that could be done in any other ward, how to rethink about the layout. What elements of the layout we can move to line up the workflow. Now, to finish, I mean, some of these principles are very much applicable to any behavior. It doesn't have to be hand hygiene. And I hope I've showed you and I've demonstrated how even very simple, unstructured observation, you know, just jotting down people's action for a week or so, can really give you a lot of information about how can you support people in making their life easier once they have to do that behavior. Because as we all know, hand hygiene has to be done hundreds of times a day. So how can I support people to do it much more frequently and when it matters? I want to leave you with this quote that it's a very common way of saying in Italy, which is actually my grandmother used to tell me all the time, which you should steal with your eyes. And that's something you can do on your daily life. Of course, is taxing, but it's a very valuable exercise to do. I thank you very much for listening to me, and I'm really looking forward to answer your questions from the QA during the Q&A section. And I include some references that kind of guided me in this presentation. Thank you very much.
Thank you, Georgia, for that very informative session. It's very important for us to get to follow up our compliance rates with the behavior issues. And as we know, IPC always has this behavioral change aspect, which is very, very important. And thank you for shedding some light on how we can get to promote hand hygiene compliances in our various facilities. I hope we're able to learn one or two things from that talk. And as she said, for those that have the questions, I can see some are already raising their hands up. May you please forward your questions through the question and answer box, and then they will be attended to during the question and answer segment. Then our next speaker, I'm going to invite Sister Christiana Conte. She is an IPC practitioner and a National IPC Program Coordinator in the Ministry of Health and Sanitation in Sierra Leone. And she also serves as the IPC pillar in lead for the COVID-19 response in Sierra Leone. She has supported the establishment of the infection control program in Sierra Leone, first as a training coordinator from 2015 to 2018 during the Ebola time. And after that, she was promoted to her current post. Professional interest focuses on the implementation of an effective IPC program in all healthcare facilities across Sierra Leone and beyond. So at this point of time, I would like to invite Christiana to come and share with us how to sustain hand hygiene programs post-outbreaks. Thank you, and over to you, Christiana.
Hello, everyone. Can you hear me, Claire?
Yes, we can hear you.
Good. It's a pleasure to be part of this presentations here, and I hope I am going to share our own experience on our side, what we've been able to achieve so far, making sure we actually have that culture of change in every healthcare worker with regards to hand hygiene. So let me now share the presentation so that we can start from that point. Okay. So as you rightly heard, the introduction from Lizzie, I am currently the National IPC Coordinator, and I just want to walk you through what we've been able to achieve for the hand hygiene program that we actually established in Sierra Leone. So let me start by the outline will look like. I give you a brief background, and also one of the products that we have successfully been able to implement, the alcohol-based hand rub, then the soap production, the liquid soap production, and then we'll look at some of the opportunities that we had, making it actually possible, the challenges that we are still faced with, and I'm actually looking at sustaining this hand hygiene products, hand hygiene beyond outbreaks. So we start looking at it to be part of our behavior day in, day out as we care for our patients in the facilities. So let me start for the participant to know where we are really coming from. Sierra Leone is a very small country on the west coast of Africa with a very small population of 7 million. But these 7 million are actually distributed in 16 districts. We have 5 regional blocks. And looking at our health system, we have 1,350 primary healthcare facilities cut across all of these districts, and we have 39 hospitals, both private and public. Let me also bring your attention back because people might want to ask, Sierra Leone, what is so significant about Sierra Leone? We are one of the countries that had the Ebola outbreak from 2014 to 2015. And during this Ebola outbreak, what came out very strongly was the high rate of infection among healthcare workers, care providers. So when we had all of these partners coming in to support us, they did a situational analysis. And what we gathered from that outbreak was it highlighted the vulnerabilities at every level of the health system. And IPC was actually singled out because we actually saw the healthcare associated infections among the healthcare providers. And we all know existing data suggests that hospital patients in low middle income countries are exposed to high rates of HAIs, higher than those in high income countries. So what we actually, one of the successes we had, we actually saw was hand hygiene played a very important role, an integral part of the Ebola response. Most of the hospitals, just like all other middle, low income countries, we have a big challenge with the infrastructure. We don't have sinks, access to clean running water, the hand hygiene products, soap, as well as even alcohol, hand rubs. We have limited supplies cut across all of the healthcare facilities. So we actually saw that the alcohol-based hand rub would be one solution to address this major challenge, because where you cannot get water in a healthcare facility, except you have the alcohol-based hand rub to support your hand hygiene practices in these facilities. So in 2015, Sierra Leone was one of the countries that actually signed up the hand hygiene pledge at the World Health Assembly meeting. And to date, we have registered 136 healthcare facilities. We have signed up the Clean Care Save Lives program. In 2016, the national program developed a 3-year national action plan. And this action plan, it highlighted 10 thematic areas. And one of them is monitoring compliance on hand hygiene practices. Because we actually saw, because of the poor infrastructure, we look at the non-availability of the supplies of the hand hygiene product, we actually saw the compliance was very low. And the objectives of the hand hygiene, looking at the hand hygiene program itself, the objective of the hand hygiene was to ensure compliance on hand hygiene practices in all tertiary and secondary facilities, and also to ensure compliance on hand hygiene practice in about 80% of our primary healthcare facilities. And one very important objective that we have worked so hard to have achieved is to institutionalize the local production of the alcohol-based hand rub. Let me walk you through our process, how it all started, and where we are today. The local production actually started in 2018. We started first with identifying the production site, because you cannot just go ahead to produce these pharmaceuticals, that you actually need a specialized, well-equipped lab for you to be able to produce. Then we went on to train those who will be actually involved in this production. We trained our pharmacists, our pharmacy technicians, and also our IPC focal point in all of in the hospitals. Then WHO, we had support from CDC to actually establish the production of the alcohol-based hand rub, but then WHO supported the procurement of these commodities and reagents. We then commenced the production using the WHO recommended Formula 1. The objectives of the alcohol-based hand rub production actually Well, we wanted to demonstrate the ABHR production process from the start to the finished product. And also we demonstrate the ABHR quality control process from primary materials to finished product, and also assess each participant's ability to perform ABHR production. Since we want this, we want it to be sustainable in all of our healthcare, in our hospitals in general, and the district hospitals. And also to ensure sustainability and continuous availability of the alcohol at hospitals after the training and the production. In the planning phase, as I rightly made mention, we assessed and renovated 2 facilities that actually met the standards that were required. As you can see on the other side of the slide, this was the checklist that we used to assess the production site. And we had 2 facilities, one in the southern region and the one in the western area for the production. Then WHO also supported the hiring of technical expertise that came in actually to support us with the training and also the production. And then WHO also supported the procurement of the equipment and the raw materials, which we readily have available in country. And these materials using the WHO Formula 1, we use the ethanol, hydrogen peroxide, the glycerin, and also we have distilled water, all of which we were able to procure locally. How we actually went about our production. Initially, we started off training 24 pharmacy and nursing staff who are also the IPC focal people. We trained them, we did the theory aspect, and also we went on to do the practical production of the handwork. The participants actually had a 3-day intensive training, and we included IPC in Sierra Leone, the burdens of HAI, the hand hygiene implementation itself, soap and hand rub consumption survey, and also hand hygiene techniques. It was actually a 3-day intensive training for these participants. The practical aspect, as you can see from the first pictorial slide there, this is the lab from the southern region. You actually see the participants. We have all our equipment there. We have the different beakers graduated in different, you have the 1,000, the hundreds, you know. The production demonstrated the local production of the WHO alcohol-based hand rub Formula 1. Then also we used the University of Geneva Teaching Hospital's record-keeping forms. We adapted that during the manufacturing and the quality control. We also had Gay-Lussac alcohol meter to check the content of the alcohol, the quality for quality control, and also to determine quantitatively hydrogen peroxide was done using the Quantifix test strips. As you can see, this is the production protocol that we actually adapted. We used the Formula 1, ethanol 96%, hydrogen peroxide 3%, glycerol 98%, and of course, sterile distilled or the boiled water, but we actually had the sterile distilled water on our side. The result, a total of 24 participants were trained initially when we started, and each participant worked as a checker and producer. And on average, we were able, or when we just started, we were able to produce 80 liters per day per team, and a total being produced per day was 480 liters, and per week, we had 2,880 liters. This was just when we just started, you know. After training, the skills are not well established, so your pace becomes a little slower. But as today, I assure everybody our production rate is very high because the participants now know exactly what they want and what they are doing. The batches we produced initially were packed into 100 ml bottles, as you can see. And these bottles, we also use them for the quality control. We quarantine them for 72 hours, after which then they were fit to be used in the facilities. But as you know, this is a low-income country. We cannot actually afford the luxury of, constantly procuring these small containers. So for us to be able to produce huge quantities that will actually be enough for our facilities, we've started packaging them in 5-liter gallons. This we can take safely to the facilities and they can just be refilling into their small containers. And also with support from FCDO, we are actually expecting more consignment of these small packages, packaged in containers for which we would want to continue using. Moving on. For the liquid soap, we started this production in 2020. During the corona outbreak, we all know what actually happened across Africa. The little pharmaceuticals we got actually dried up and the prices were so high, they elevated all the cost of the product, alcohol hand rub, as well as the liquid soap. And at one point, in fact, you couldn't find liquid soap in the pharmaceuticals. So with the technical expertise, we also, as a national program, we started production of liquid soap. This one started in April during the COVID-19 outbreak. We also started off by identifying production sites for which, as I'm talking now, we only have one production site, also in the southern region. This one we actually placed in the hospital, the regional hospital in the south. And then it was followed by training of the national staff. The national officers in the program, they are actually supporting the production with some few IPC focal people. Then, of course, we went further to procure the machine and ingredients. This is locally produced also, and we also have the ingredients readily available in country. As you can see, the political will, we actually got the Minister of Health. We got the Minister of Health to unveil the production sites, as you can see it on the left-hand side. And then these are the finished product packaged. You see the national officers actually displaying the finished product of the liquid soap. And our finished products, normally we take them to the central medical stores from where distribution to the various facilities are being facilitated. On the left-hand side, you can see the alcohol production, and then on the right-hand side, the liquid soap production. The amount of, if you look at this slide, we actually followed the quantification tool that WHO have provided, and we were able to come up with the consumption from our hospitals cut across the country. So we can successfully estimate the quantity of alcohol that we need to be distributed in our facilities, following the tool at 20% compliance and also at 40% compliance. The opportunities that we have that have brought us thus far, we are very much grateful because we had the political will for the fact that they actually accepted all the requests made from all our partners, supporting partners, to be able to establish the effective IPC program. That was a plus. And also we have designated trained IPC personnel in the health facilities. These people are actually, they are designated to monitor IPC activities, and hand hygiene compliance is one of their great roles that they perform. We also have IPC structures at all levels of care. We have established the IPC program in every facility. And for now, we have support from our partners, CDC, WHO, FCDO, ICAP, and also other implementing partners. And the one good opportunity that we can boast of is the availability of these ingredients that we do have locally in country. And also for the production of the liquid soap, we have the machine being produced locally also in one of our factories. And another great opportunity is the management buy-in. Today, you go around all the facilities, you actually see management as role models in our facilities because they now appreciate and they really know the importance of hand hygiene in actually minimizing healthcare associated infections in their facilities. And I'm also proud to say that these two products we've also registered with our pharmacy board in country. Despite all of the good opportunities we have, we still have challenges. And the one major challenge that we are still faced with is we don't have designated budget for our IPC program. Without budget, you know what that means. You have a lot of limitation in proper implementation. And the behavioral change, the behavior of colleagues, of healthcare providers, even when you have everything provided for them, it's a long journey for us to actually achieve that. Inadequate wash infrastructure, it's a real limitation, for you to be able to achieve effective hand hygiene practices in all of the facilities. So sustaining hand hygiene beyond the outbreaks, what we think we can put in place to achieve that, we need to improve on the facility infrastructure because the facilities need to have clean running water. Otherwise, it becomes a bit difficult. We also need budget allocation for the program because we really want today the partners are supporting the production. So if we have budget allocation for the IPC program, we can still continue production and we can do that, sell that one out on a cost recovery basis to all of the facilities. And I think if we also embark on regular hand hygiene campaigns, that can also be reminders for all care providers, and we can sustain hand hygiene practices. Regular and adequate supplies of the soap and alcohol hand rub, these ingredients are needed for us to be able to sustain hand hygiene practices in our facilities. Our regular hand hygiene audits also is very, very important for us to be able to sustain. Giving feedback and also follow up on action points, action plan after you do this regular audit. Also, we need that supportive supervision and mentorship at all times. You also need to keep the checks and the balance, and also you need to support the healthcare providers. If we really want to go further, we need community sensitization through media engagement, because you can imagine all of these relations, they follow their patients onto these healthcare facilities. So we really need to sensitize them also to know the importance of performing hand hygiene. And then we also need that functioning IPC committees in healthcare facilities, because at these committees, you can actually discuss, some of these challenges and find a way forward. And we also need to identify hand hygiene champions, because that's a form of motivation for us to be able to sustain these regular practices. And above all, we need to strengthen our HAI surveillance, particularly SSI, which we have started as a country to guide our IPC interventions. In conclusion, I would want to actually say the government, together with other partners, are supporting our local production of both the alcohol and the soap with technical support from WHO. And prior to COVID, the consumption rate was a bit lower. We estimated at 48,000, but today Our consumption rates have doubled with the increased awareness to perform hand hygiene at all times. The demand for commercially available ABHR pushed us actually to produce these two hand hygiene products because of the cost. And if you compare the cost of our local production and that of the pharmaceuticals that are coming in, you can actually see the vast difference. We've also done that comparison in the market. Our local production is costing something like $2 to $3 per 500 mils compared to $10 for 350 mils containers. As I'm talking today, we have up to 30,760 liters of alcohol produced and 36,000 liters of liquid soap currently produced, and we have safely stored in our central medical stores. So on the overall, I would say ABHR and liquid soap production is feasible in low resource settings, and that can actually provide alternative to unavailable and unaffordable commercially produced products. I must acknowledge the following: our ministry for the support and the recognition, WHO for their support, technical support, and also our donor partners who are actually supporting us to be able to achieve all of our goals. DB, CDC, FCDO, GIZ, and of course, World Bank, and all other implementing partners. Thank you all for listening. I will now open up for any question and answer.
Thank you, Christiana, for that informative talk and giving us a first-hand experience of that alcohol-based hand production and soap production is possible in low middle income settings, and also getting to bring out the important role in which the managers and also the political will plays in the success of any infection control program, especially with regards now to hand hygiene, which we've been talking about. Thank you so much for that. So at this point in time, we are going to start our question and answer segment. And amongst the panel, we are also graced by Madame Mary Fuller, who is the Chief Nursing and Midwifery Officer of the Ministry of Health and Sanitation from Sierra Leone, and is very passionate about supporting and implementing the IPC programs. We are also graced by Yolanda Van Zyl, who is the current chair of the Western Cape IPC Society and also serves on the National Advisory Committee in the National Antimicrobial Resistance and IPC. And she has also been instrumental in the drafting of the South Africa hand hygiene guidelines. Sorry, saying Ms. Yolanda Van Zyl, she has been instrumental. She has been instrumental in the drafting of the South Africa policy on hand hygiene, and not so sure whether it has been rolled out or it's still in draft form. So without wasting much time, then also on the panelist, we have Dr. Zayed from WHO EMRO, and also Alice from WHO HQ, and also Dr. Dege from Zimbabwe. And I'm going to pose some questions to the panelists, starting with Georgia. There was a question from Nala Suleiman, who is asking, what is the frequency of compliance for hand washing? Over to you, Georgia.
Thank you very much, Lizzie. Thank you for the question. Just to clarify, do you mean what's the level of hand hygiene compliance in the world? Is that what has been asked?
I think he was asking on that, the overall compliance.
Yeah, so I think it varies a huge amount. I would say both in high income and low income settings, it's still suboptimal. And in the last 10 years, there has been huge improvements, especially a big project drive from the WHO Global IPC unit who pushed for a WHO multimodal strategy to improve hand hygiene. And that has definitely showed evidence that hand hygiene can be improved. But I would say that hand hygiene compliance can always be improved, and it remains low in many settings. And so it can vary between 10% and usually never reaches 100%, but it can go as high as, sort of observed 60, 70, 80%. Thank you very much.
Thank you, Georgia, for that response. Then my next question is to Christiana. We have noted in your presentation that with the COVID pandemic, you have seen an increase in the rate of alcohol-based hand rub production. And our question is, has it translated to an increase in hand hygiene compliance amongst healthcare workers? Over to you, Christiana.
Mm-hmm. Yeah. Hello, are you getting me?
Yes, we are getting you.
Oh, great. Yes, I can say it has actually increased, but currently we are, as we've started this year 2021, we want to embark on an effective IPC observational audit in all of the hospitals so that we can actually get a proper rate of the increase in the compliance. That we are just starting, but yet also because of the second wave, a lot is being done. The IPC program is actually being stretched out, but that is what we want to do. But on the overall, I want to say clearly that the ABHR, the uptake of the alcohol-based hand rub in the facilities actually increased during this COVID response, because we actually saw, everybody actually saw the need, to perform hand hygiene at all times. And we've actually seen a marked reduction in the transmission of COVID in the hospitals, in all of the facilities. So that's one we are yet to actually do a proper audit for us to be able to say this is the compliance rate as compared to before we started. Over to you.
Thank you, Christiana, for that response. My next question is directed to Yolanda. Yolanda, what has been your experience with regards to promoting hand hygiene behavior strategies in your hospital or the facilities that you cover? And how have you managed to sustain good compliance rates in these facilities? Over to you, Yolanda.
Hi, good morning to everyone. My name is Yolanda and I'm an infection control practitioner in a regional hospital in Cape Town, in a town called Paarl. So basically, just sharing my experience before COVID, everything went so well. We were starting to implementing the WHO multi-model strategy, and we started with system changes, putting alcohol hand rub at point of use, or at point of care, sorry, and then gradually working our way through the multi-model strategy. I basically used the WHO framework as my blueprint. I only implemented it in my facility. So it went very well. And then with COVID, I must say, like an advantage was that people were definitely more aware of hand hygiene, and people were definitely more compliant, and we could see that our adherence rate is going up. But by saying that, like the system change we made with the point of care, we had to open extra beds, extra wards, which didn't have that bracket at the bottom of the bed. So yeah, some of our things didn't work so well. We had to improvise and just put the bottle on the bedside. But that's small things that you can change on a later stage. Yes, and then just something I'm thinking about, Lizzie, in your initial remarks, you asked about the hand hygiene policy for South Africa. So what actually happened is it is built into our national IPC manual. So instead of having a separate document, we build it into the IPC manual. And you know that the national IPC manual was launched in March 2020 due to the pandemic and the need for people to have guidance. We're very proud of it because it's the first time in 10 years that there's actually a final document. The document was in draft the whole time. Yeah, and coming back to my experience with hand hygiene and behavior, I think someone mentioned it, giving feedback, immediate feedback, presenting to management on progress is very valuable, and it does change people's perception. And the one thing I always say is if somebody can relate to it, if you can make it like personal, like what if that was your mother in the bed, would you still not perform hand hygiene? And I think that is what COVID brought us, is that personal thing that you could see your colleagues getting sick and family members getting sick, and you know the importance of hand hygiene. So I think that is the one positive thing from COVID, and we hope to sustain it and keep people informed about the value of hand hygiene, and yeah, let them perform it in a way that makes sense to them. I hope I answered your question, Lizzie.
Yes, thank you for that, Yolanda. Then next, now a question directed to our colleagues from WHO, Alice or Dr. Zayed. There was a comment from Mr. Joseph Mtetwa, who was saying, is there a way in which we can indicate in the alcohol-based hand rub that it contains ethanol, or which quality assurance methods can we look at which can demonstrate that the end product does not have any contamination? Over to you, Alice or Dr. Zayed.
Thank you so much. So hello, everyone. This is Alice Simniciano. I think this is a bit difficult to answer, as the local production indicates just that we provide the prescription of how to do it, or rather the recipe, but we cannot really assess the quality of those materials being put together from a distance. So it's difficult for us to advise on quality control measures. I believe there are indications on the production guide of what to look for, but I'm not sure that we can provide input on how to identify if there is any contamination. I'm not sure who you're mentioning, Dr. Zayed is. Is that Bassem? I don't see him on the call.
Oh, probably maybe he dropped off due to the internet connection.
Okay, so yeah, so sorry, I don't have a good answer for that, because it's difficult for us to assess that quality assurance for local production. So that's one of the weaknesses of using that method for producing your own alcohol rub solution.
Thank you so much, Dr. Alice, for that. Our next question is directed to Christiana, and it's coming from Yani Chitambala. Or she says, what are some of the challenges faced in the implementation of local production of the hand rubs in terms of regards to some bureaucratic processes in certain departments? So basically, I think it's just asking with the challenges that you encountered.
Yeah. As I rightly mentioned in my presentation, we do have challenges. We do have challenges because we don't have a budget on our own. We rely on this support, the donor support. The success so far is because we are having donor support, and they are actually supporting us to even procure ingredients and also packaging. They are supporting us as at now. So our major challenge actually is for our ministries to actually see how they can invest into infection control, so that they can have a designated budget for IPC program implementation in the country. They have different priorities, the leaders, they have their priorities, they differ. So that is our major challenge for us to actually get them to support the full implementation by setting aside a budget for IPC. Over to you, Lizzie.
Thank you, Christiana, for that. My next question is then directed to Dr. Dege from Zimbabwe. Dr. Dege, you've been involved in implementing and supporting IPC programs, and from a managerial level. And since we heard in one of the presentations that at times less hand hygiene is usually perceived as more of a nursing thing than for other healthcare workers, what has been your experience with regards to sensitizing different cadres or different professionals in getting to adhere or to promote hand hygiene programs? Over to you, Dr. Dege.
Thank you very much, Lizzie. My experience has been that generally hand hygiene practice is a difficult area, but what we have tried as much as possible to do, because as management, we're non-clinical managers have been sensitized. We have also gone on to ensure that we train our non-clinical staff as well in terms of IPC, including hand hygiene, and make sure that hand hygiene products are available even in offices, and making sure that we also monitor even the use of the hand hygiene products in the different offices. So yes, it's a challenge, but it can be done as long as the management is committed to ensure that everybody is engaged and everybody is sensitized and also is supported to ensure that they actually properly implement good hand hygiene practices. And you continue to monitor the practices, and also to continue to support, and also make sure that these hand hygiene products are actually part of the hospital budget as well. It's very critical. You bring in your accountant, you bring in your administrators, so that they also get to prioritize the procurement of these products on the budget. And even at national level in Zimbabwe, I think we have now prioritized the production of hand hygiene products locally, with our tertiary institutions getting involved in a big way. So to a greater extent, you also need management to be really keen on ensuring that hand hygiene is being practiced at institutional level. And for us, we also monitor other facilities in the province. We also ensure that hand hygiene is a critical area. Just like yesterday, I was actually out monitoring one of the facilities, and we could also realize that still, even though we are in a pandemic, you still need to be able to continue to emphasize the issue of proper hand hygiene, because there were some practices that we actually met which were not up to standard in some of the facilities we visited. So it's still that critical that management continues to take it on board. Even in meetings, these issues should be discussed at management level. Thank you.
Thank you, Dr. Dege, for that response. Then my next question is directed to Georgia. This is a question coming from Ron Kefa. He says, what's the best approach for improving IPC in a health facility? Is it pursuing all standards simultaneously or starting with high impact and open courts and low-hanging fruits, for example, like hand hygiene, and then moving on to other standards? Over to you, Georgia.
Thank you very much. I don't think it's an answer that can apply to all contexts because it depends on time and resources that each context has. But I would, personally, from my experience, it's a bit easier to start with, as you said, high impact areas and lower hanging fruits, and then build on that. Of course, everything is a priority. One thing you can do is also to understand what matters to your employees and to the health workers. And you can start from that because they're more willing to change their behavior if they think something matters. So that's one way to go about it and prioritize. But starting with quick wins might also build people's confidence that change is possible and build on it with more difficult strategies. Thank you very much. Over.
Thank you, Georgia. And now I'm going to ask Ms. Sitembiso Masego to ask your question. Sitembiso, may you please type your question on the question and answer segment? And also Margarita, your hands are up. I don't know whether Susan, we allow them, you can allow them to ask. Hello, Susan. Susan. Okay, while we are dealing with that, we have a question to Christiana. This is coming from Dennis. It says, do you experience complacency in terms of hand washing? If so, how are you dealing with it? Over to you, Christiana.
Yes, of course, there is complacency in attitude all over. You go to every facility, you see people, they tell you, no, you know, I'm playing with water all the time and the like. There is complacency. But by and large, today with the sensitization and of course, with the outbreak, I think the COVID-19 outbreak and the measures stipulated for prevention or breaking that chain of transmission, that actually have increased the compliance. People now really performing hand hygiene. They're washing their hands. You have the alcohol, they're using it. But then you still have some amount of complacency. But then if you actually educate them on the importance, and we now back that up with the COVID, you know, the COVID outbreak. So people, you put some amount of fear in them and they actually say why they need to wash their hands. So that's the only approach we need to take, because it's all about behavior, you know. Somebody perceiving that if I wash my hands, I will be safe. But then gradually, people are getting to actually appreciate the need for them to regularly perform hand hygiene at all quarters. Over to you.
Thank you, Christiana, for that. Yes, Tembiso and Margarita, we haven't seen your questions on the chat box. Susan, maybe you can assist by unmuting first Margarita and then secondly Tembiso so that they can ask their questions. Thank you.
They can unmute and speak. Sitembiso and Margarita, I've allowed them to speak.
Okay, Margarita first. You can ask, and then followed by Sitembiso. It seems their mics are still muted. May you assist?
Good afternoon. Good afternoon.
Oh, afternoon, Sitembiso.
Yes, mine is unmuted, but I think my question was responded to along the way. I just want to congratulate the team from Sierra Leone for a job well done. Otherwise, thank you so much for the informative presentations. We are learning quite a lot. Thank you.
Thank you, Sitembiso. Then over to you, Margarita.
Very much. I've got the same thing as Tembiso, but I just want to congratulate everybody with what's been said. And I've gained a lot of knowledge, and especially in South Africa, we all thinking that we are alone with the sustainability of hand hygiene and how to influence the whole department. And it was very interesting. I think it was Chrissy that said that starting with a pharmacist and things. So there's a lot of work still for us, but I would like to say thank you very much. This was the first session that I didn't even want to drink tea. So thank you so much.
Thank you, Margarita, for that. And then we are going to take our last question, which is directed to Christiana. This is from Miss or Mr. Funmilayo Adams. He says that since you are having funding currently from the donors and partners, is there going to be a sustainability for local production in Sierra Leone, which is government-led after the funding has been exhausted? Over to you, Christiana.
What we are actually pushing now at the ministry level, the leadership of the ministry. You know, as a country, we have UNICEF that does the procurement of all our medical supplies. So at the leadership level in the Ministry of Health, we are now actually negotiating, lobbying with our leaders for them to actually see, instead of these entities procuring from overseas, how they can actually invest in procuring locally, so that that can be a revolving fund that we can always buy ingredients and produce so that we have it available at all times. So that is what is ongoing right now. As I said in my presentation, I actually involved the leadership as the minister himself and also the chief medical officer. These two people were actually at the production site, and there's that buy-in of the efforts we've made so far to be able to achieve that type of, in innovation in the country. They are very much impressed, but yet we are still pushing so that we can actually take over that two components whenever they are procuring for all medical facilities. Thank you.
Thank you, Christiana, for that response. At this point of time, I would like to thank our presenters for today. Thank also the panelists, and also thank the participants who have taken for an hour and 30 minutes to contribute and listen to this webinar. And as we earlier on said, the slides will be shared through your emails. So the recording and the slides, you will get them through your emails. And we are going to be issuing certificates at the end of the series. The series has 6 sessions. And for you to get a certificate, you have to attend at least 4 out of a total of 6 of these sessions, and you have to attend for at least or for over 1 hour. So at this point in time, I would like to thank you so much and also encourage you to keep safe and let us all promote infection control in our various healthcare places and the various places of work where we are practicing. And we hope to see you again next week, Wednesday, same time. Thank you and over.
Thank you, Lizzie. Thank you to all participants.
Thank you.
Yeah.
Hi, Lizzie. Thank you so much. Bye.
Bye.
Thank you.
I'm gonna end
please,
now.
yes, and please make sure that you also join the community of practice where we have the deliberations on some of the topics that are being discussed during these webinars. Thank you and over.
Thank you.
Bye.
Bye.
Thank you. Bye.